Hello and welcome to the LEAPcast. On today's episode, we're talking to Becky Cotton, who is co-founder of Lumino, an app for mental health during menopause. And we're going to be talking about how digital health can engage hard-to-reach populations.
Welcome. Becky, could you just give us a quick background and tell us what led you to co-found Lumino?
Well, thanks for having me. It's great to be here. I guess I've spent most of my career, I've had a funny career up until this point, and I suppose the sort of golden thread has been working at the sort of intersection of healthcare and technology and social change. So my main sort of guiding mission has always been, how can we expand access to good treatment to people that need it, regardless of how much money they might have in their pocket? And I'm a big believer in how technology, when it's built with all the right clinical rigor and everything around it, can improve people's mental health and overall health. And so Lumino, my co-founder Mo and I founded that in 2020 in lockdown.
Oh, right.
But before that, I worked in healthcare for, about 15 years. My last, as I call it, proper job, I was a director of mental health policy at the NHS Confederation. And I did loads of things in that job, but the thing that I'm probably the most proud of is that I helped set up and chaired for a while the UK's mental health policy group, which brings together a lot of big non-profit organisations like Mind and Rethink Mental Illness, as well as professional bodies like the Royal College of Psychiatrists. So I was kind of very happy for the most part doing that and was working on stuff that I really, really believed in. But I think I couldn't quite get out of the back of my mind this idea that, actually, it's going to take a lot more than just lobbying for more money for these services to make real change, and kind of starting to get a bit itchy to actually do something and build something, and starting to think about what that might look like. I did a Churchill Fellowship, which is a fantastic organisation. They sponsor people to go and do mini fellowships, to go and explore what people in other countries are doing to tackle big social challenges. And I asked if I could go to America and Australia to look at how digital technology was being used to support better mental health.
Right.
Terrible gig. How they will have 2 months away doing something like that. But it was fantastic. And I got to spend time in the health system in Boston, spend time at Harvard, and spend time sort of in Melbourne and Sydney, and all these people doing amazing things. And I really started to think, well, actually, so there is a massive opportunity with technology to expand access. Being quite a conservative, I'd hesitate to say industry, but sector, healthcare is quite rightly conservative in a lot of ways. It does move quite slowly because, the risks that are involved in getting things wrong, they're about people's lives. And so that's understandable that a sector like healthcare is probably not going to be at the forefront of adopting loads of new technology as opposed to lots of other sectors in the economy.
Yeah, those technology sectors are very much more move fast and break things, whereas the things you're breaking in health tech are human beings.
And so it's much more a case of, my co-founder has a poster up in his office at the moment, which is about move slowly and mending things rather than move fast and break things. Because you're right, the risks are very real. But it was lovely sort of spending time in Australia and the States, meeting people that were taking on that opportunity, but doing it really, really carefully and thoughtfully, and starting to think about, well, actually, maybe what I might do next is something in that sector, in that health tech sector. So that led to co-founding Lumino and thinking, well, I've got an idea. I can see a gap that's not being served very well. See if we can do something about it.
So can you tell us a bit about Lumino? What is Lumino?
Okay. So we founded Lumino as a company that would build evidence-based digital therapeutics. So for those people listening who maybe are not that familiar with digital therapeutics, we're very used to having apps and tools on our phones and wearable devices these days that help with our health, but they're not necessarily designed to actually provide a clinical grade intervention. They're not something that your doctor is going to make officially part of your treatment pathway. They're not making any massive claims about what they're doing. Those people that are in that space and doing it well and responsibly are very modest in the claims that they're making for them. An awful lot of people find them very, very helpful. Similarly, there's an awful lot of websites out there and online tools that are all about giving people communities and peer support and things like that. That's tremendously valuable for an awful lot of people dealing with long-term health conditions, but they're not necessarily clinical intervention.
Yeah, and that's not their aim, right?
And that's not
they're trying to be, that makes total sense.
Digital therapeutics, though, are a sort of subset of digital health, which is all about, actually, could we use some of these technologies like wearables and smartphone apps to deliver a clinical grade intervention that you might be able to make available as part of a package of somebody's care? And there's some really good examples of those sorts of tools that have been developed and are being actively used in the NHS. So Sleepio is a really good example of one of those sorts of tools, which is all about, if you go to the doctor and you're having a hard time sleeping and you've got insomnia, at the moment, the evidence base around that is kind of sleeping pills or CBT or some other kind of psychology-based intervention could be really good for you. But the likelihood of you getting CBT on the NHS for insomnia, unless it's a very extreme case, is probably not going to be made available to you. But what Sleepio have done is make that available at a very low cost for people. And it has a really great evidence base behind it. It has multiple RCTs and stuff like that. So there are examples of these tools already out there, but there's also lots of areas where we know other sorts of clinical interventions might be really helpful to add in to support that people are already getting, but they're currently not. And that's usually because we either don't have the staff to do it, or we don't have the money to do it, or in some cases, patients and members of the public are kind of reluctant to engage for some reason or another. And that might be because of time or just being able to fit it around their life. So digital is a really great opportunity to tackle some of those challenges.
Right. Yeah, that makes sense. So how did you come about choosing what Lumino was going to tackle specifically? Is Lumino digital therapeutics in general, and the first problem that you've gone to tackle are menopausal mental health issues? Is that correct?
It's exactly that. And I think coming from the background that I've come from, I'm just very interested in how you can use psychology as a way of supporting people to have better health, because our mental health and our physical health are so interconnected. And the thing that I was always really interested in when I was working on policy was, we're very used to talking about psychology interventions for people that have depression or people that have anxiety. Actually, we all have mental health, and physical health challenges can be really challenging for our mental health. And there's there's great evidence that it's helpful for all of those sorts of people going through all those sorts of things.
So Steren is Lumino's first digital therapeutic and is menopause specific, and it's CBT based. Is that right?
Yeah. So when we founded the company, we knew we wanted to develop digital therapeutic tools, but we were thinking about, well, what should that first product really focus on? We wanted to do something where we knew there was a good case for CBT being a helpful intervention for a patient group, but that currently that's generally not very well available for people. And there's a whole host of health conditions and other sort of life stages where we know that's the case, right? So we could have just as easily picked teenage mental health, for example, or people with COPD, or people with diabetes, or, there's so much unmet need in our system. And so actually deciding first to focus on is a really tough decision, actually. But I guess there were a few things. One, I'm a woman of a certain age, and I've thought, here's a problem that is a real, genuine problem in our system, that we live in one of the richest countries in the world. It doesn't always feel like it, but we live in one of the richest countries in the world. And women in midlife go through this transition. It's not an illness, but they go through a big transition. There are interventions that we know can be really, really helpful to them, but yet they don't have access to it. So CBT is in the NICE guidelines now. It's a recommended kind of, that should be part of that conversation people are having with their GP when they turn up and they're having symptoms. That GP hopefully should be able to have a conversation with that person about HRT if it's appropriate for them and they want to, But also there's a whole host of other things that might be helpful for that individual, and CBT is one of them. We know that an evidence-based intervention is not the same as actually getting people to be able to access any kind of support based around that. So we wanted to do something in that space. If we could do something that would just help people who may benefit from some of the tools and techniques that are pretty general across an awful lot of CBT-based interventions, to be perfectly honest. The tools and techniques you learn in CBT with your therapist, if you're lucky enough to be able to access it, are the same tools and techniques generally, whatever kind of problem that you're dealing with.
Right.
And can be very, very helpful. I think they're helpful for anyone. So we thought, why don't we try and develop a way of building a program that helps people understand what some of their symptoms are all about and ways of dealing with them, but also introducing some CBT-based tools and techniques that they may find helpful as they're going through that transition. And so that's what Seren is all about.
Right, yes. And I'm also a woman of a certain age. And it's not like menopause is a niche condition.
No.
It's not a small population that we're talking about, even if they've been previously overlooked. Was that part of the decision-making process, that just because it's a typically overlooked population doesn't actually mean that it's a small population? That must have played into the commercial decision-making to an extent.
It's a huge, look, it's very underserved in all of, if you look in any healthcare system across the Western world, the story is the same, which is it's a very, very underserved cohort of people. And also women's lives are changing in midlife as well. Sort of 20 or 30 years ago, we did not have women, certainly not as many women as we do now in sort of really senior jobs, having incredible careers into their 50s and 60s and beyond in some cases, who want to stay at work and do all those sorts of things. I think a lot of the sort of individual stories of it maybe got lost. But there's a moral case to be supporting women better in midlife, but there's also a business case for it too.
That's such an important point, because as you say, obviously there is the immediate benefit to the patient themselves, but then there's a wider benefit to their employer if they're able to turn up better, be more engaged in their work. So
yeah,
the branching out of these things is important and also equally overlooked, especially now that women have such a key role in the wider workforce. So I'm curious as to what point you involved women in the design process. Was it sort of fairly early on or at the evaluation stage?
It was really early on, really early on, before we even put pen to paper and started designing what we might possibly build. And I'm a big believer in that. If people cast their minds back to that first lockdown that we had in COVID, it was a really weird time. It feels like a very long time ago, but I guess there were an awful lot of people who suddenly had an awful lot of free time and were at home. So that included me. And I just supposed that on Twitter, and I just said, I'm kind of spending a bit of time thinking this through. I'd just really like to talk to anyone who's been through this about, what was their experience like? What symptoms were people having and how did that impact their life? But also, what was their experience of going to the NHS or any kind of health service to get help? What were you offered? What helped? What didn't help? Just to start to, before you even start designing anything, just to understand what people's stories were. And probably just a reflection of that particular point in time. I was overwhelmed with people
That's amazing.
Were happy to do that. And so I spent a lot of time on Zoom in the corner of the living room, just having conversations with people about their experiences. And I'm really grateful to every single one of those women. I think there's a danger for innovators of sort of starting with a solution. They can fall in love with the solution rather than the problem and think, I've got this amazing idea for how you solve X. It's tempting to leap to, oh, this is what it could look like and this is what it could do. But if you don't fully understand the variety of experience amongst the cohort of people you're designing for, then you might be setting yourself up for issues later on. So we just spent ages talking. I mean, we talked to probably about 50 women individually, maybe more than that in lockdown about this experience. Once you get to about 20, there's a number of narratives that come through again. You have a good sense of what people's experiences have been like across a large chunk of the population at that point.
I guess if you don't do that, there is a risk that you don't fully understand the problem, even if you think you do. And that risk is potentially a financial risk. It's not just an ethical issue, that's a delivery issue. It just won't work in the way that you think it's going to work. So it sounds like doing that at the ideation stage was really invaluable for you.
Yeah, and it does take time, but I think it's really important not to rush that bit.
If you do rush it and you carry that risk through, the risk is failure. So then ultimately that's going to be more costly than if you just take the time now.
I mean, the innovation is inherently really risky, insanely risky. Most things will fail, and that's okay. It's just about what are the things at each stage of that development that you might be able to de-risk it with. And before you start plowing lots of money into developing a piece of software that you think is the right solution when actually you haven't really tested it out yet, it's just about de-risking. But most things probably will still fail.
Yes, that is true, unfortunately. Was there anything you learned during that phase that changed your mind, changed direction?
Yeah, tone. That was the thing that was actually really, really helpful. There's a few sort of trends in women's health. There's a bit of a pinkification going on.
Yes.
Like everything being so girly and cute about women's health that I think a lot of people are quite fed up with.
Maybe menopause particularly. It's not very
well,
cool.
I think now particularly, I mean, there's an awful lot of toxic positivity. Some stuff that I think people are kind of quite sick of. Just snap out of it. There's a bit of that I think a lot of people can find quite invalidating. And there's also some, there's been some horrendous examples of kind of menopause services and products being advertised that sort of make it sound like menopause is the end of the thing world.
Yeah.
And,
so somewhere in between the two, somewhere between it's the new puberty or it's the end of the world.
You don't have to have a six-pack and be, running an Ironman, but similarly, you don't need to be weeping in a corner that somehow you're not going to have your periods anymore, as if that's something of a, a terrible thing to happen. Do you know what I mean? So it's finding that sort of tone of voice that is clinical and is credible and kind of trustworthy and is based in evidence, but also isn't eternal and talking down to people.
It sounds like your population has been with you throughout the process. When you start, you've had that ideation phase, you've done, would it be fair to call it a degree of co-design?
I think it's really sort of co-design. I think it sort of covers such a broad spectrum of kind of work. And I think really for us, it's been a question of sort of listening to people's individual stories, trying to pull out what are some common presentations, iterating on ideas, like showing them so we went through an alpha version, which we showed people and got their feedback. Based on that, we went back and designed a beta version, which we tested out and gave some more thought to some of the feedback that we got from that. And we've just finished building our launch version now. And then at each phase, you're kind of talking to women and also involving them in some of the content as well, thinking about sort of people's stories and stuff like that. I'd like to involve more women from that point of view. But I think, you need a community of people around you that it's not a sort of, I think in healthcare, there's always a bit of an us and that there's a sort of like, here's the healthcare professionals on one side, and here are the, whether you call people public experts by experience, people who are just not healthcare professionals, but know what they've gone through because it's personal. But in reality, the categories are far more blurred than that. You can be talking to people who have immense expertise in one area or another, but then have also been through it, or their wives have been through it, or their girlfriend has been through it, or whatever it is. So I think it's about sort of bringing a community along with you and kind of asking for their feedback and learning from them to try and build something that reflects their needs.
So like a community that you bring with you that comprises your population, but also the sort of people who will be delivering it. And actually, those are not mutually exclusive.
And it's a very broad set of people. So, the people that I think about that are around us, there's an awful lot of women who've been with us from the start, who've been very generous with their own experiences. There's people from my old life who kind of help me make sense of what the policy landscape for this is, and like actually the commissioning in the NHS. And that varies across different countries in the UK as well. So that there's clinical communities, but sort of academic clinical communities in different disciplines. So we've got gynecologists and psychologists and psychosexual therapists and all sorts of people involved. And then you've got people who are designers and software developers who, might not have necessarily touched a health product in their lives, but that are really passionate about it and want to bring their skills to bear.
It sounds ideal. So will the launch version be classed as a medical device?
Yes.
It will.
Yeah.
I'm very curious. So our first podcast episode was with Paul Jewell from Zurich, and he spoke to us a lot about kind of what it takes to, well, first of all, how do you define a medical device? And then sort of this quite murky world where you've got software and AI as a medical device. What I'm really curious about is what's the sort of evidence that you need to get that classification?
Well, first of all, it depends what classification, because of course medical devices are in different grades. Class 1 medical device, which is sort of making very modest claims, not making any claims about sort of changing symptoms or altering the pathway of care or anything like that, but that is generally about supporting someone's well-being, quality of life. The evidence bar for that is fairly low, to be honest, because you're not trying to show a sort of change in symptoms or anything like that necessarily. That would come later if you were looking at a class 2A, 2B kind of medical device. But there's a whole host of other things that sort of go into certifying as a medical device that are just good data governance and like being able to kind of demonstrate that you've kind of gone through the right processes and procedures and you've got the right policies in place and all that sort of compliance piece that give people some peace of mind in being able to use your product. I think what we see, that's a very complicated process, I think, making sense of medical device regulations. Post-Brexit, we're diverging from Europe, and that's adding another layer of complexity in there for an awful lot of companies like ours. I think what you see in the market is often a lot of startups just trying to skate some of that.
Okay, yes.
And going, oh, we're not a medical, we don't want to get anywhere near being a medical device. And so you only have to go onto the App Store. There are a lot of products out there that claim they're not medical devices, but clearly are.
So it's almost the opposite of what I would expect, which is that everyone's sort of clamoring for that classification, but actually, no.
No.
That's so.
I mean, if you want something to be made available in the NHS, the NHS are very good about sort of like, here are the standards you need to comply to. But if you want to be taken seriously in a healthcare setting, absolutely, you need to take that seriously in the sorts of claims that you're making. But I think there's a lot of time and cost associated with doing that.
So these procedures, essentially, from a user point of view, work towards building trust, which I would argue is an ethical imperative. But yes, it sounds like beyond that, it's actually crucial from a delivery point of view, because as you say, without going through those procedures, you won't be able to be prescribed eventually, if that's your aim. Yeah. So actually trust should be baked into your design.
Yes.
Right.
100%. But I think that compliance is, as you will expect, right, that there's a high bar for this stuff. We are talking about developing stuff that is about treating people and supporting them with their health problems. It's a proper thing and it should be taken seriously. Navigating that can be pretty complex though too.
Yes.
And trying to understand what are the areas of regulations that apply to you and what you want to build is not always straightforward.
I was also wanting to ask about the evidence that you used to build the tool.
There's huge evidence base around CBT across all sorts of different conditions, and there's commonalities between lots of those intervention protocols and what have you. delivering something via a smartphone is so difficult. If you think about, if you were to go see your doctor tomorrow and say, oh, do you know what? I think I'm dealing with depression and I could really do with just a light touch CBT kind of intervention. They'd probably refer you down for 6 sessions of CBT at an hour a bit. Who's going to sit down with that phone for an hour? I can barely sit down with my phone for 5 minutes without jumping between different sorts of things. You're wanting to support people to learn. It's a completely different experience from doing that face to face. But if people are able to learn some of the common tools and techniques, and you're able to do that in a way that is sustainable for them over a smartphone, then hopefully that might have a positive impact on their lives. But it's completely different developing something face to face.
What you're talking about is the children asking you questions about their homework, the cats fighting in the background. That's what you're competing with. You're competing with real everyday life. And that's very different to assuming people will be sat down uninterrupted for an hour.
So you're learning from all sorts of things. And some of that is completely outside of healthcare. You're looking at sort of like, well, actually, how do you create experiences through a phone that are engaging, that people want to come back to? Now, in some cases, you might be looking at Instagram and some of those sorts of tools who kind of are able to engage people incredibly well. You're developing essentially a protocol from scratch with clinicians about, okay, given what we know about what tends to work in digital health, given what we know about what tends to work in terms of smartphones and engaging people in education, as well as a really great ripe ground for looking at stuff that works, thinking about how you might develop a protocol like that. So it's not really a case of sort of, you can't just take an existing protocol and it doesn't.
It's super interesting. Our most recent episode, I chatted to Ray Newman, who's a content designer who's done work with the NHS. And he had some super interesting stuff to say about how you design what you interact with. And we specifically spoke about, especially if you're going through some sort of health issue, you are not having a good day necessarily. And most products are designed with the assumption that you're fully engaged, you're fully able to concentrate. Yeah. We talked a bit about trauma-informed design and kind of assuming that maybe your cognitive and emotional load is already a bit overwhelmed. And if you don't do the correct user research as to how actual humans living their lives interact with it, you have a huge risk of it going completely wrong. The final thing I wanted to ask you about when we're thinking about hard to reach populations was about funding.
I guess the question about how you, like with these sorts of tools, how on earth do you kind of secure the funding to be able to build them? And a lot of kind of startup programs or, and there's plenty of them in Bristol and things like that. There's plenty of them across the whole country.
The incubator model.
Yeah, they'll take very early stage, idea stage innovators who've got a really promising idea. Maybe they've prototyped something and tested it with a few people and it looks kind of promising. And then they'll be like, okay, well, how do I get the money together to be able to build this thing? And if you rock up at sort of any number of those sorts of programs, some of them are much better than others, I will say. But often what a lot of people get told is you should go and raise some angel investment. Go out and raise venture capital. That's a great idea. And I think the thing that I always say to idea stage entrepreneurs is take all of that advice with a pinch of salt. If you want to develop anything that will have the need for some degree of clinical evidence before you launch it, it's very unlikely that venture capital is going to be the right model for you at idea stage. Might be later. But at idea stage, those funds will need their money back quickly.
Right. So do you have alternative sort of funding streams that you would recommend?
So I think what we've done is we didn't raise venture capital early, very deliberately. I think that's not necessarily the case with angels, because I think with angel investors, their motives were many and varied. And there are some wonderful angel investors out there that know full well the complexity of the space that health innovators are working in and want to support. We also have a lot of people who call themselves angel investors, but actually just put £500 on a Kickstarter thing and then put angel investor in their bio on LinkedIn. Those people are like my nemesis. But there is something about what are the alternative ways of being able to fund this stuff, especially if you're not an academic, sort of being able to get multi-million-pound grants to build this kind of thing and then study them and maybe spin them out. But I think I would encourage people to have a look at Innovate UK. They've been great to us very early on. Also NIHR, National Institute for Health and Care Research, they've been fantastic with us as well. And we're very lucky in this country to have that kind of early stage innovation funding. The people that I'm probably most grateful to, though, is the Scottish Government. So we were part of the CivTech programme, which is a phenomenal public sector innovation programme they have there. And if they've got elections happening in Scotland this year, I hope to God whoever comes in keeps that programme, because it's an absolute jewel that other countries are quite jealous of. But they've been incredible in supporting us. And the Scottish Health Boards there have been amazing. So we're based in Bristol and in Glasgow. And I think, there are opportunities available that are not just about spending the next 6 months of your life putting a pitch deck together and talking to every single angel investment group in town or venture capital. But it's probably not going to be where you're going to get your first check.
Would you say that's especially true if you are, if your population is targeting a traditionally underserved group? Are you going to struggle more to get traditional routes of funding?
Well, I think if you're targeting any kind of population or buyer, and that they're not the same things, the NHS being one of them, any kind of population where perhaps there isn't so much of a massive market, then yes, you will struggle with some of those more traditional things, because venture capitalists are looking for a 10x plus return on their investment. That's why they're there. That's not a bad thing. That is exactly why they're there, to take a big swing. And, all power to them. But if you don't think that you've necessarily got $1 billion business or an idea that could become $1 billion business, you probably don't have any reason to be thinking about venture.
My final question. If there is a team listening today who want to work with an underserved population, what's the first thing they should change in how they work?
Well, it depends what they're doing already. They might be doing amazing things already, but I think just getting out there and talking to people and thinking very deliberately about the people that aren't coming forward to talk to you. That's something that we really have tried very hard to find ways of getting around. If you go out and you want to talk to women about their experience of menopause, what you'll often find is that a lot of the people that have the inclination to talk to you will probably look a bit like you. And in my case, that means you're kind of a white, middle-aged, middle-class woman. But that's not representative of the whole country or the whole community that you're trying to serve. And so trying to find ways of talking to people who don't come from communities like yours, I think is really vital.
Who are we quietly excluding?
And being mindful about it, we're the ones excluding them. Those communities are out there. It's our job to try and find them. They're seldom heard. In the NHS, they used to use all the time, which I used to hate, hard to reach groups. They're not hard to reach.
Just haven't tried.
Just haven't, they're just not reading the same things you are.
Brilliant. Becky, thank you so much. This has been a really useful chat.
You're welcome. It's been good to be here.
If you enjoyed this episode, follow the LEAP podcast on Spotify or Apple Podcasts and sign up to our mailing list to find out more.